first of all, I wanted to start with just context. So there have been emerging zoonotic infections that have been going on. We've been tracking very carefully for decades, but they've been probably going on for millennia. And zoonotic infections basically are infections that are common among animals or endemic among animals, and then we as humans incidentally get infected. And we're seeing them more and more because we as humans are encroaching into kind of natural spaces. So, you know, tearing down rainforests and going into grasslands and other places. And so we're basically, humans are in closer contact with natural fauna and flora, and basically more opportunities for these types of infections, animal infections, to jump over to humans. So what you're seeing on my slides are that we've been tracking, even in the past 20, 30 years, a number of infections, and some of them are names of infections that might be familiar to you, like Ebola, dengue, Zika, chikungunya, MERS and SARS, and even avian influenza. So COVID-19 represents the latest version, and certainly the thing that separates this zoonotic infection is because it is highly transmissible among humans, making it a pandemic. So my next slide is really just to describe what we know so far. So just in general, COVID-19 infection appears to be a mild infection for most of the population. So 80% of people that get the infection will honestly recover from it. They may have disease where they have to be bedridden and stay at home and really have minimal kind of energy for about a week, but then eventually will recover. But there are still a significant amount of people that will get serious disease and require hospitalization and close observation. And that means that there will be 5% of people that may require intensive care unit and mechanical ventilation. And right now we're seeing, anywhere between 1% and 3% case fatalities. Of course, these percentages are really out of the cases that we know about. There's emerging information now that we're seeing that there is a lot of asymptomatic and mildly symptomatic disease. So maybe the fatalities are much, much less among the true infections, but we don't know the number of true infections because a lot of it is asymptomatic. Among the people that get the infection, we know that people who are at higher risk of having more severe disease, meaning hospitalization, needing mechanical ventilation, or having death, is older age. Those who have immunocompromising conditions, which could be cancer-related therapies, transplant, HIV, or maybe some of the immune modulating therapies for rheumatologic diseases. And then other chronic conditions such as hypertension, diabetes, heart, lung, kidney, or liver disease are also conditions that predispose a person to having more severe COVID-19. So a lot of what you've been hearing about in the lay press and kind of communicated from national leaders is the importance of what we call non-pharmaceutical interventions, or NPIs. They're also called community mitigations. So I'm looking at the pink square right now. And this is really all the things that we're able to do right now with public health, which is quick isolation and quarantine upon contact of cases and then their close contacts. Social distancing. We like to now try to use the word physical distancing because we really don't want to socially distance or socially isolate people, but we do want to kind of close schools and businesses, have travel restrictions, cancel mass gatherings, and have a 6-foot rule. So really it's that physical distancing between people is what we're trying to implement. And then of course, infection control, cleaning high-touch surfaces, laundering frequently, and then hand hygiene, cough etiquette, those sorts of things. And all of this is intended to really delay and flatten the curve. So if you look at that purple peak that comes early, what we're trying to do is flatten it and delay it. So that's the 1, 2, and 3 there that you see in the figure. And all of that is intended to really reduce the overall burden on the healthcare system, which means all of the hospitalizations and ICU care and mechanical ventilations, which are a precious resource. So one of the things that I always try to communicate to people is that you don't want to be someone like a patient A. This is a figure from a pretty famous publication from SARS back in 2002. And this was a patient that came from the Guangdong province, stayed in a hotel in Hong Kong, which is termed Hotel M, then became ill and was hospitalized. But during his stay at Hotel M, he came in contact with multiple people, and then through his hospitalization, in contact with people. And he stayed on the 9th floor of Hotel M, and there were the 12th floor, I think, of Hotel M, and there were 9 other people that stayed on that same floor that came down with SARS. There were other people who came in contact with him while on an elevator ride in Hotel M. But anyways, what you can see in that figure is that there were secondary infections from those close contacts that became infected, and then tertiary infections. And on the whole, you can count 268 cases from this one individual. Again, so this is kind of trying to stress the importance of all of the things that we're trying to do with physical distancing measures. I also wanted to kind of relate the importance of not being a super spreader. So not only can you just infect close contacts, but you yourself could be a super spreader and promote multiple different infections. So here's another publication from SARS where an index patient led to 4 generations that were counted in this tracing and led to 76 additional cases through those 4 generations of close contacts. So again, we don't want to be a super spreader. We don't want to be like a patient A. So this is really my last slide that I would cover today. And so here we've done a lot of modeling exercises, a lot of groups throughout the US and throughout the world. And these models are only as good as the assumptions that are built behind them, but they are a good tool to help us to visualize kind of different scenarios. And here they're layering on kind of the different interventions and what happens to the peak if you layer on all of these interventions. How much do you delay it? How much do you flatten the curve? And so here, the bottom line is that I wanted you to see that, these interventions are effective, but they could result in us having peaks that could be as early out in this model as December. So, and in other scenarios, we're talking about COVID-19 maybe disappearing over the summer, or at least diminishing greatly over the summer, so that we can have opening of businesses and for us to be able to travel again and those sorts of things. But there's a scenario where in the fall we may have a resurgence when the weather starts to change and get cooler, and again when we have the typical opening of schools and those sorts of things. The timing of the fall time is another thing that's under discussion by a lot of different groups and the government as well. So this is kind of to give you an idea of the complexity of how we're trying to plan for the COVID-19 situation. I don't have a crystal ball, but this just gives you an idea of some of the different scenarios that we have to think through as we try to think about whether or not we can open businesses and open schools. And I think, again, in the context of global education, we have to think about what our students and faculty will potentially encounter, whether they might be travel restrictions by certain countries, our own country, or whether or not we frankly think that it's safe as an environment to allow some of our students and faculty to travel at this time.